I'm going to be covering biliary neoplasms and jaundice today. That's one of the core modules for this week. Apparently there are 5 core modules you've got to cover for this particular topic. So I briefly went over it, and I've got my own presentation, but some of the important stuff that's highlighted in that in this core website, I'll just point it out to you or discuss it with you, and then we'll go back and forth between slides and this. So the first learning objective, of course, is to talk about knowing, whether when somebody has jaundice, you got to identify if it's direct versus indirect and the different causes of it. In regards to today's particular topic, the two things. When somebody has obstructive jaundice, they'll have direct hyperbilirubinemia, but it could be either from choledocholithiasis versus some malignancy. And so the important thing here that they point out in a patient who presents with jaundice and in whom choledocholithiasis is suspected, the first test to order will be ultrasound. So that's important. That's something that may show up on your written boards. That'll be the first step. And then for patients with malignancy, they would like you to identify procedures for different diagnosis, which could mean CT or in some cases ERCP, EUS with tissue diagnosis and stuff. The second important concept that I found interesting as well was in a patient with obstructive jaundice suspected to be from choledocholithiasis but with a history of bariatric surgery or altered upper GI anatomy, such as a Roux-en-Y gastrojejunostomy. Important thing is the resident considers gastrostomy tube placement as a means of providing access for ERCP. Now, where would you put the gastrostomy tube in somebody who's had bariatric surgery? So somebody's had Roux-en-Y gastric bypass. Where do they propose putting the G tube in? Well, probably be in the remnant stomach, not in your not the part of the stomach which has the Roux-en-Y, because that's just going to go down through the jejunostomy. But it's the remnant stomach that's hooked up to the first and second part of the duodenum. So in order to get access for the GI colleagues to be able to do an ERCP, that's important to consider a G2 if they can't, they've tried and they can't get into the afferent loop and go back, that's one way of doing it. And this is important as well. Patient undergoing endoscopic common bile duct clearance for choledocholithiasis. Subsequent cholecystectomy is indicated as it lowers rates of mortality, recurrent biliary pain, jaundice, and cholangitis, and decreased need for repeat ERCP. So ideally, that's why the recommendation is if somebody with choledocholithiasis or biliary pancreatitis, you perform a cholecystectomy in the same admission. So essentially, the 3 different causes of jaundice, obstructive jaundice that they want us to discuss. One of them is gallbladder polyps, the other one is gallbladder cancer, and that would be both for incidental and somebody with preoperative diagnosis, and for bile duct cancer. So we'll briefly review those. So gallbladder polyp.
This for the senior chief residents, this retained stone and the whole algorithm, all the way that Shuja talked about, is in your oral boards, as well as they will give you the patient has Roux-en-Y bypass. They want to tell you that how you want to act. This is very important for the chiefs, even at E.A. Conway, Harris. So it was on, as you know, it's on the oral boards.
Yeah, absolutely. So let's go over this. So ultrasound of gallbladder reveals a polypoid lesion. This most likely represents which of these? Cholesterol polyp, adenomyomatosis, benign adenoma, adenocarcinoma, inflammatory polyp. So what's the most common polyp found in the gallbladder? Yeah, so cholesterol polyps are the most common polyp, that's right. So gallbladder polyps, cholesterol polyps, they're the most common, usually the small in size, less than 1 centimeter. They're pedunculated and usually multiple. On the other hand, adenomyomatosis, this is just essentially hypertrophy of the mucosa. They're sessile, usually greater than 1 centimeter in size, and have microcysts in them, which may help identify these lesions on ultrasound. So adenomas, on the other hand, can be difficult to distinguish from adenocarcinoma. And the gist of it is, when do you operate for gallbladder polyps? So the three clear indications. One is all symptomatic polyps. A patient comes to you with right upper quadrant pain, ultrasound, they don't see gallstones, but they see some polyps, and patients having pain. So that's one indication. Any polyp that has is greater than 1 centimeter in size, because the risk of malignancy in polyps greater than 1 centimeter in size is moderate. So that is one indication for removing the gallbladder. And the last indication is polyp in association with either gallstones and any other risk factors for adenocarcinoma. And one other it's a relative indication. Some textbook will tell you anybody with polyp and age either greater than 50, some books would say 50, or some books would say greater than 60 years. So anybody with any polyp of any size but age greater than 50 or 60 years is a relative indication as well. So again, with regards to the core module about gallbladder polyps, same thing. Most gallbladder masses are benign. Incidence of polyps in asymptomatic populations about 5%. Adenomyomas are benign masses of hyperplastic mucosa in context of hypertrophied muscular layer. Gallbladder polyps most commonly found are incidentally found and are asymptomatic. This is important. So how do you distinguish gallstones from polyp on ultrasound? Three criteria they've mentioned is for stones, it will be hyperechoic, posterior shadowing, and it will be mobile. So it will have these three features, gallstones would. On the other hand, a polyp will have variable echogenicity, so not always hyperechoic, will not have posterior shadowing unlike stones, and is usually non-mobile. So that's important. Again, that may show up on your boards. So that's important to know. Next thing to discuss would be gallbladder cancer. And again, this is in terms of either incidental finding versus finding on CAT scan that makes you suspect it's gallbladder cancer. So it's an aggressive malignancy. Essentially, some book textbooks will tell you that this malignancy carries a worse prognosis of all biliary cancers. So, essentially the prognosis is worse than even the bile duct cancers. One of the reasons for poor prognosis is late presentation. Usually manifests in patients in their 60s or 70s, more common in women, 3 times more common in women than in men. Pathogenesis essentially is the inflammation is the root cause of this, and there's some risk factors, essentially 3. Most important is gallstones. That's the primary risk factor. Larger stones, usually greater than 3 centimeters, will carry higher risk of malignancy, so that's important. So in the patients that you see, especially women in their 50s, 60s on ultrasound, if you see that they have a stone that's greater than 3 centimeters, that's one reason you got to start thinking ahead and say this patient may have malignancy. Important thing is there's no relation to the type of stone. So there's several different types of gallstones, but regardless of which type you may have, all of them carry equal risk for malignancy in the long term. Next risk factor is porcelain gallbladder. This is essentially calcification of the gallbladder that you've had for long-standing calcification that results in gallbladder cancer. This is relatively controversial. Sebastian, I read through Sebastian yesterday. They say that clearly that is one risk factor, even though they say only about 10% of patients with porcelain gallbladder will develop cancer. But there are papers out there, they've looked at studies, and they've concluded the porcelain gallbladder is not a risk factor. But SCORE wants you to sort of stick to Sabistons who will take that. So it is a risk factor, although the risk is low. And then
Calcification matters in this, like I kind of read that porcine gallbladder, there are two types of calcifications, like the way the pathogenesis is.
I'm not familiar with that.
I'll try to look up that article again, but you're right. I think the risk used to be high in the past. It's coming down now.
Yeah, because they've looked at it more closely and they don't think it is. But Sabiston still says there is about a less than 10% chance. So my teaching had been that it's not, but I was surprised too when I read this. So, and then finally, the gallbladder polyp, anything greater than 1 centimeter in size, you got to suspect that your patient may have malignancy. So adenocarcinoma staging. So of all the gallbladder cancers, adenocarcinoma is the most common. Important thing to know is that usually at presentation, there will be metastatic disease. So 35% of the patients will have nodal disease on presentation, whereas about 40% may have distant mets. Important thing is the draining lymph node for the gallbladder cancer would be the hepatoduodenal ligament. And that's relevant because when you do a radical cholecystectomy, this is one step of radical cholecystectomy is to clear out all the lymph nodes along your portal triad, because this is the lymph node area that drains the gallbladder. And then venous drainage of the gallbladder is direct venous tributaries into the liver, and so that explains the spread to segment 4 of the liver. And that's why, again, radical cholecystectomy involves removing segment 4B and 5 along with the lymph nodes in the portal triad. So that explains why we need to do it, because concern and risk for spread. Staging, again, the important thing for staging is you need to know the T1 and T2 staging. That's the most relevant in terms of your decision making, what needs to be done. So T1 is tumor invades into the lamina propria. T1B is invades into the muscular layer or the muscle layer, while T2 essentially it invades into the perimuscular connective tissue or the serosa. That's more relevant. So as long as it invades the serosa but doesn't pierce the serosa, it's a T2. But if it penetrates the serosa, then it's T3. So T1 is into the lamina propria or muscular layer, and T2 up to the serosa. And the staging, again, is important because they may phrase this kind of question in your oral boards, either giving you the T1 stage, or the stage in terms of T1 N0 MO, and ask what's the next step for gallbladder cancer. So that's why you need to know what these, at least know these 4 to be able to answer those questions. So stage 1 is T1 N0 M0. Presentation, most of these occur in the fundus or the body of the gallbladder, and that's why they don't have any symptoms until advanced disease, because it's by that time spread to the liver or to the lymph nodes or even distant mets. Jaundice, important point is jaundice in a setting of gallbladder cancer is a poor prognostic indicator. So if you have a patient who has jaundice along with gallbladder cancer, that patient will have poor prognosis. Other presentations may be patient may have some weight loss, and again, in extremely advanced disease, you may even be able to palpate an abdominal mass. So how do you make your diagnosis? Again, first step, anybody with right upper quadrant pain or jaundice, usually you'll request for an ultrasound. So you'll either see a mass in the gallbladder lumen or subhepatic space that should make you suspect, malignancy or some kind of mass. And again, important factors would be it'll be non-mobile, probably be hyperechoic, and no posterior shadowing. There will be asymmetric gallbladder wall, polyps greater than 1 centimeter. Again, you suspect malignancy. In this case, this is just out of the Sabiston textbook. They've shown the arrow indicates, they say there's a break in the continuity of the gallbladder wall, which in this case they're trying to show that the gallbladder wall is actually invaded into the liver, adjacent liver. Next step, would be after ultrasound, you suspect there's a mass in the gallbladder. You would, next step would be to get a CT scan, because that defines the mass better and will also be able to evaluate for any distant mets. So important thing you'll be looking for is peritoneal mets, liver mets, and the lymphadenopathy along the portal triad. And also if you do a triple phase CT scan, that will tell us if there is any vascular involvement either of the portal vein or the hepatic artery. This is just a CAT scan of the gallbladder cancer, but it seems to have invaded into the adjacent liver as well as into the duodenum, the second part of the duodenum. So again, important thing with this is sometimes they may present this in several different ways. Classically, they may say somebody has a gallbladder, has standard laparoscopic cholecystectomy, but then on pathology in order to have gallbladder cancer, and then they may put it as either T1A, T1B, T2, or stage 1. So at that point, then they'll ask you for the next step. So for any gallbladder polyp, and this is an elective setting where you have somebody on gallbladder polyp noted on ultrasound but greater than 1 centimeter in size, recommendation is to actually perform an open cholecystectomy, because we're concerned that with laparoscopic, if there's perforation when you're dissecting the gallbladder of the fundus, of the fossa, there could be perforation and spillage, and so that may contribute to spread of the cancer. Gallbladder polyp less than 1 centimeter in size and you're removing it because patient's symptomatic, then you can proceed with laparoscopic cholecystectomy. It doesn't have to be open. But open is for any gallbladder polyp greater than 1 centimeter in size. And this would be the classic scenario. They may discuss gallbladder cancer after cholecystectomy, where you did a laparoscopic cholecystectomy standard, patient went home, then you see him in clinic, and then you're looking at pathology, and then you note that, okay, it's gallbladder cancer, and again, based on the staging, will determine what the next step is. So, T1A lesion for gallbladder cancer, standard laparoscopic cholecystectomy is adequate. You don't have to do anything else. T2, which would be what? We talked about T2. What's T2? That's right, but not penetrating it. So, T2 would require a radical cholecystectomy, and radical cholecystectomy has 3 steps to it. So one is that we talked about portal lymphadenectomy. You excise the segment 4B, 5 and 5 of the liver. An important thing to remember, most textbooks don't tell you this, is you have to check with your pathologist what the margin, if the margin or the cystic duct margin is negative, positive. Because if it's positive, then what? Then what do you do? So essentially, yeah. So if the cystic duct margin, then you'll have to resect the common bile duct, and would have to end up doing a hepatojejunostomy. I'm sorry.
I think they talked about going up to the right side, right common bile duct. You have a negative frozen section.
Yeah. So essentially, you have to resect the common bile duct and then send for frozen. And again, if it's distal to the bifurcation, then you're good. You just have to do a single hepatogej. But if the frozen section comes back positive, then you go back till the frozen section comes back negative. Now, if that means you have to go past the bifurcation, then you may end up having to do 2 hepatojejunostomy to the right and the left. But that's important. Cystic duct margin will be important. And again, most textbooks, even Sebastian doesn't mention that. So that's an important aspect that you have to consider. Is if somebody comes in with on pathology, you have positive gallbladder cancer, then you have to go back to the pathologist, have them review whether the cystic margin is negative or positive. If it's negative, then all you need to do is portal lymphadenectomy and segment 4B5 resection. But if it's positive, then it becomes a more complex procedure. You have to do hepatojejunostomy. T1B is the controversial area. As we said, T1A, nothing to do, nothing more besides cholecystectomy. T2 would be radical cholecystectomy. T1B is relatively controversial. Some people will tell you lap chole or cholecystectomy essentially is adequate, and others will tell you no, you need radical cholecystectomy because the concern is T1B lesions may have higher recurrence rate. So, if I were, my teaching has always been T1B cholecystectomy is adequate. So again, I would leave it up to you guys. Either way would be correct. There's no wrong or right answer with this. So, but I'd feel comfortable saying simple cholecystectomy is adequate. There wasn't much in terms of the core module with the and again, same thing for T2 gallbladder cancer, as we talked about. Resident will recommend treatment by specialists. Understand this will include resection segments 4B and 5 and portal lymphadenectomy. Again, even this does not mention anything about looking at your cystic duct margin, but you have to do that. There isn't much different to what we've talked about. And this was the elective. Yeah, there wasn't much to add with this. Incidental diagnosis of gallbladder cancer is approximately 1 out of 150. So bile duct cancer, this is a relatively broad topic, but I try to sort of, summarize it as best I can. With regards to bile duct cancer, you have intrahepatic and extrahepatic. For this particular topic, they want us to restrict ourselves to the extrahepatic bile duct cancers. And so the extrahepatic bile duct cancer, there are 3 different types. One is, of course, the proximal third or the perihilar, also called the Klatskin tumors, and these are the most common of all the bile duct cancers and carry the worst prognosis. Then you have the middle third, and then the distal third, which would be the periampular region. So this is the bismuth classification for the Klatskin tumors. So important thing is type 1. It involves up to the bifurcation but does not involve the bifurcation. Type 2 involves the bifurcation but doesn't go into the primary biliary radicals. Type 3A, important would be that it involves a bifurcation and involves the primary biliary radicals on the right, in the right lobe of the liver. That's 3A. 3B will be involving the bifurcation and involving the primary biliary radicals on the left lobe of the liver. And type 4 will be involving the bifurcation as well as the right and left primary biliary radicals. So that's the bismuth classification. Again, I don't know if they, at least they wouldn't ask this in my time. I don't know if things have changed. Have you ever had a question pertaining to this on your app site? Any one of you? Not that you recall? Yeah. But I guess, they expect you to know that. So risk factors for bile duct cancer, again, just like gallbladder cancer, the pathogenesis is from chronic inflammation, which could be from choledochal cyst, congenital. And again, the important thing with choledochal cyst, we all know the Todeni classification. There are 5 different types of choledochal cysts. But the important thing with all of them is that there is an anomalous union of the pancreatic biliary duct with all of those. So essentially the pancreatic duct where it comes in into the bile duct and goes into your ampulla, there is some kind of anomalous union which causes essentially reflux of all the pancreatic secretions into the bile duct, causing inflammation, and that contributes to a malignancy in the long term. So it's important that you know that there is always in all choledochal cysts there's an anomalous union of the pancreatic biliary duct. So that's important to know. Other risk factors would be infection, recurrent cholangitis, and primary sclerosing cholangitis. And again, just as an aside, primary sclerosing cholangitis is associated with ulcerative colitis, and this is one condition where a total colectomy for ulcerative colitis can reverse a whole lot of conditions, I believe, in even arthritis and other conditions, but it will never reverse the primary sclerosing cholangitis, so that's important to know as well, because I remember having one of those questions once on AppSite. Which of these conditions will not be reversed by total colectomy? So types of bile duct cancer, 3 different types. Sclerosing is the most common type and associated with the Klatskin tumor, which is the proximal 1/3. Associated with periductal fibrosis in a concentric pattern with circumferential duct occlusion. Not that important for you guys. The second most common is the papillary type, which is a polypoid lesion noted in the bile duct, and nodular will present as a nodular mass in the duct lumen. Again, staging, all you need to know is that, at least I'm as far as I know, I think as long as you know T1, T2, I think that'll probably be adequate. T1 tumors are those confined to the bile duct, and T2 are extending outside the bile duct but not invading the adjacent structures. So it doesn't involve the liver and stuff, probably just involves the connective tissue around the bile duct area, but it hasn't gone really into the liver yet. So that's T2. Once it invades adjacent structures, it becomes T3. So T1, T2 carry better prognosis, of course, because they haven't locally invaded yet. What are the poor prognostic indicators in bile duct cancer would be if there is direct local invasion, which means if it's a T3 lesion, and there is local lymph node spread. Presentation again, just for any other mass in the biliary tree, you'll have painless jaundice, you may have pruritus, dark urine, steatorrhea, you may have clay-colored stool. Workup for labs, the first thing when you send out blood work and you suspect a mass in your biliary tree, you'll find direct hyperbilirubinemia, you'll have elevated alkaline phosphatase, and then in this setting you'll also send CA99 and CEA. Again, they're not very sensitive. They may come back as high or normal, but if they do come back high, the value is actually allows them to, if you're able to resect the cancer to an R0 resection, and somebody had an elevated CA99 when the mass was first identified, then you can, periodically check for CA99s to see if there's any recurrence. After the blood work, the next step, of course, would be the ultrasound. Again, you'll see ductal dilation, going into the liver, but ultrasound will not tell you the exact site of obstruction. So the next step would be either to do a CT scan or an MRI, which will help better identify where exactly the lesion is, as well as identify if there's any distant spread. Important thing is, you do not, if somebody meets criteria for resection, you do not have to have tissue diagnosis for resection, prior to resection. Just like you don't have to have tissue diagnosis for somebody with pancreatic mass that seems resectable but has features of pancreatic malignancy in CAT scan. You don't have to have tissue diagnosis before you proceed with surgery. Same thing here. If somebody meets criteria for resection, then you don't have to have tissue diagnosis. You can just take them to the operating room. So in that setting, but if somebody has distant spread, metastases of both lobes are involved, and so it's unresectable, at that point you would need tissue diagnosis. Francesca, why would you need tissue diagnosis if somebody has distant spread peritoneal mets? You're not operating. Palliation would mean what? What aspect of palliation? Why do you need tissue diagnosis? If somebody is obstructed, you want to give them a metal stent. Why do you need a tissue diagnosis? I'm sorry? That's right. So oncologists would never give chemotherapy without a tissue diagnosis, no matter what the setting is. So that's why you need chemotherapy. You need a tissue diagnosis for palliative chemo and radiation. ERCP does carry a risk of cholangitis if you were to go after tissue diagnosis in setting of biliary mass. treatment, again, as I'll just briefly go over it. So type 1 for the proximal clad skin tumors, for type 1, you would just have to resect the common bile duct, or the hepatic duct in this case, up to the bifurcation, and then you can proceed with a choledochogegenostomy. Probably you can get away with just one anastomosis. For type 2, which involves the bifurcation, you'll have to resect up to the bifurcation. Sometimes you even may have to resect the caudate lobe of the liver. And in this case, you'll probably end up having two anastomosis, two hepatocogegenostomy, one for the right, one for the left. Type 3A, where you have the primary biliary radicals on the right side being involved, you'll probably end up resecting the right lobe of the liver. You'll have to resect the bile duct onto the left, get a frozen section, make sure you have negative margins on the left, and then you'll have to do a hepatocogegenostomy to the left side. 3B, the exact opposite, so you'll have to resect the left lobe of the liver and go up to, on the right, take a frozen section, make sure your resection margin is negative for any malignancy, and then do a hepatocogegenostomy to the right biliary radicals. And type 4 will, again, you'll have to go resect the primary biliary radicals for both the right and the left, and then essentially do an anastomosis to the secondary biliary radical on both sides. Important to remember would be, if this was involved, these are the secondary biliary radicals, on both lobes of the liver, then that's a contraindication to surgery. Then that becomes an unresectable disease. So up to the primary biliary radicals is okay. But again, the anastomosis, you'll have to, it's just the further down you go on the biliary radical, the smaller they are, and so the more complicated and more complex the anastomosis will become, and so the higher risk of leak rate. For the distal bile duct cancer, essentially you end up doing Whipple, is what you would do. So this was it. With regards to the module, again, there wasn't much that they added that I could find in terms of the resident has to recognize that surgery remains the mainstay of therapy for cholangiocarcinoma, and that adjuvant chemotherapy radiation has not been proven to be beneficial and only gives marginal survival benefit. So important thing though is R0 resection. You have to have R0 resection for this. R1 resection will not really prolong your survival. So that's important. So when you undertake surgery for bile duct cancers, you got to be absolutely sure that you'll be able to get an R0 resection. The R1 resection is as good as not resecting at all. Questions?